in while doing this, you are getting time to, check for the pathology. So bilateral 12 ribs are normal, sir. Intercostal space is normal. Okay, the lung pathology appears clear. I'm looking at the cardiac silhouette. It's normal. Bilateral hemidiaphragm is normal, and the vertebra, I think, is normal. See, 15 seconds, you have seen everything. I think, sir, it is a normal chest X-ray. Got the point? So that is the way forward. Okay, so that you don't have to wait and break in between. Come, next chest X-ray. Start first. Normal chest, yeah, frontal chest X-ray view. First start.
So this is the frontal chest radiograph.
Yes.
So the scapulae, clavicles, and
Yes.
the ribs are normal.
Yes. Lung field appears normal.
Uh,
Whatever.
the lung field appears normal. The cardiac silhouette is normal. However, there is a triangular shaped retrocardiac opacity in the left paravertebral region.
Yes.
Um,
Doing what? Again. Mass lesion.
so it's elevating the
Does it?
medial.
Yes.
It's
Doing
elevating
what?
the medial aspect of the left hemidiaphragm.
Very good. Pointing
Um,
towards?
the triangle apex is towards the mediastinum, the medial
Hilum.
aspect.
Hilum.
Yes.
Triangular opacity pointing towards the hilum that you have described. If you have described outer this thing, okay, it is silhouetting the medial left hemidiaphragm. What about the left border of the vertebra? Is it silhouetting, not silhouetting? Plus minus. Okay. Will that be okay?
Yes, sir.
Is that got air bronchogram? No air bronchogram. See, I'm just asking things which you know, but you are not describing. Air bronchogram, not air, no air bronchogram.
So no bronchograms, no calcifications,
Very good. Anything else?
and
Air
no
ho gaya, fluid. You will rule out fluid. You will
yeah,
rule out calcification.
yeah.
Any air fluid levels? See,
No, sir. No
you have
cystic
gone into the
or
diagnosis. That is why it is not coming in your mind. You've gone into diagnosis of what it is. I would say it's a lung abscess. I mean, just imagine. Then you have to think on those lines also. Obviously, it is a left lower lobe collapse, but I would say it's a lung abscess. You're getting the point. So in that case, air fluid levels, all those things also has to be just negative findings. You have to just rattle. Just say again, fast. So this is a triangular retrocardiac triangular opacity seen with the apex pointing towards the hilum. Left hemidiaphragm is obscured. और उसके बाद there is no क्या क्या no है इसमें? Sure, you
so
muted.
there is no calcification,
Very good.
no bronchograms,
Yes.
no it's a homogeneous opacity.
Very good.
There is no
Fluid
lucency
levels.
uh, within the patch. There's no lucency,
Very good.
no air fluid level.
Very good. So these are the things. Anything else which you think is striking? Here, anything said. So let's discuss this also. Air bronchogram you have ruled out. Consolidation is out. Air fluid levels nahi hai. Most of the pathology you have ruled out. You are looking towards collapse probably. What is the next thing? If there is a collapse, what happens to mediastinum and the left lung volume? Striking.
So the left dome of diaphragm would be elevated.
Very good. Is it elevated? Not elevated.
Yes, sir. It's at the same level as the right, so it's
Right
elevated.
dome. Okay. Very good.
The hilum could be pulled downwards, the left hilum.
Very good. Yes. So left hilum is higher, right hilum is higher. Matlab for you, and your normal chest X-ray.
So left is higher normally.
Yes, so यहाँ पे left is lower. If you can
Yes.
see, the apex of this. This you know, but you have to just practice. Okay. Next, what about the volume? Lung volume reduced, mediastinal shift. Is there anything?
No, sir. There's no mediastinal shift.
Okay, chalo, subjective, but I would say it is yes. But okay, कोई बात नहीं. That's okay. Lung volume.
So rib crowding is not seen.
You see the X-ray from 2 feet distance. You will see that the left lung, the volume is less. The right lung, the volume is more. Okay.
Okay.
Just see, have a look. Then you will appreciate that. So now you have described this as chest X-ray frontal view. Everything else is normal. There is a retrocardiac opacity pointing towards with the apex towards the hilum. The left hemidiaphragm is obscured. Maybe the left paravertebral. This thing is stripe probably is obscured. The left heart border is visualized. Where do you think the lesion is? Anterior mediastinum, middle mediastinum, posterior mediastinum?
So posterior.
Why?
So the cardiac silhouette is not
Is not in. Okay.
obscured, and there is, like you said, plus minus obscuration of the left vertebral border.
Okay. So what I want you to say is that whatever I told you up till now, you have to tell in one breath. Okay. And now what is your differential diagnosis?
So I'll describe it again, right? The radiograph.
Oh, okay. Please go ahead. In 30 seconds.
So on a frontal chest radiograph, there is a well-defined soft tissue opacity in the left retrocardiac region, which has smooth margins. It is obscuring the medial aspect of the left dome of diaphragm and also obscuring the left vertebral border. The cardiac silhouette is normal. There is no calcification, lucency, or air bronchograms within. And it's pulled the left hilum downwards, and the left dome of diaphragm is pulled upwards. With a reduction in the left side lung volume. In view of these findings, my differential would be a left lower lobe collapse, predominantly involving the posterior segments, because the hilum is seen separately, the cardiac silhouette is not obscured, and the vertebral shadow appears obscured.
Okay.
Yes, sir.
That's like a KM resident. Okay. That is like a KM resident. So it's a left lower lobe collapse. Fine. One thing we missed was the left descending pulmonary artery. Are you able to visualize that?
No, sir.
This is the left descending pulmonary artery. You are not able to visualize that. This entire retrocardiac, this thing just takes it in and goes down. Okay. So that is how you differentiate between a normal and an abnormal collapse. I will show you the other pictures. What is this? You don't have to describe. Just where is the pathology? Just say where is the pathology. Okay, pathology is somewhere here. Near, I mean, it can be missed, but here the thing is that the left descending pulmonary artery is not visualized, and that is how you suspect a left lower lobe collapse. Is that okay?
Yes.
So that is the way it is. So now we have this as left lower lobe collapse. We have this as left lower lobe collapse, very steep collapse, and this is normal chest X-ray. Okay, let's come to this. This is what do you think all the 4 X-rays are? You same things? Same thing. So there is a retrocardiac opacity on the left paravertebral side, obscuring the left margin. No air bronchogram, no calcification, no air fluid levels. There's a loss of lung volume on the left elevation of the left hemidiaphragm. The left hilum is pulled down, and there is an hyperinflation of right lung with contralateral herniation. These are the words you have to just, rattle it out. Hyperinflation of the right lung with contralateral herniation. This is through the retroesternal space. Always the lung herniation takes place to the retroesternal space. CT में बहुत commonly दिख जाता है, but here it becomes a bit So same thing is this side. This is the collapse. You are not able to see the left hemidiaphragm, and there is a pathology here too. Okay, here the pathology is here, and here it is a very steep collapse. Okay, so these are the basically collapse things. Now, why I have made this X-ray? I'll just this is like the now the physics of silhouette sign. Why I have made this is that this anterior, middle, and posterior. I think that you can clearly take it from Sutton. So this in collapse, the collapse part, if it is a posterior lobe or a lower lobe collapse, it basically silhouettes and obscures the diaphragm. So there are two hemidiaphragms out here. So doctor, can you just tell me which one is left, which one is right? Swachh?
Yes, sir. The posteriorly, the one which is seen above is left, and the one which is seen lower is right, based on
Okay, but
obscuration of
okay.
the
So in this the question is
the heart.
okay. In this the question is, this is a left lateral chest X-ray or a right lateral chest X-ray? We will. Could you get into the physics part of it? It's okay. So this is the normal chest X-ray. See, it is not that chest X-ray which we are following, and where the right, just the right hemidiaphragm is higher and the left is lower, right? We all know this. Is that okay? Is that okay?
Yes.
Ah. So here, which one is higher, which one is lower depends on whether it is a right lateral or a left lateral. If it is a right lateral, when the right side of the diaphragm is near the film, then the appearance is different and left appearance is different. There is radio physics involved. You people can, read it. At times, examiner asks you. Okay. So secondly, this is left or this is right?
So right.
Very good. Because the anterior margin is clear and it's very clearly, sharply defined. So this is right. And this is left because it is arising posterior to the cardiac shadow and it is going below. Fine. So right, left, these are two things. And then third thing is that in below the left, you see a stomach bubble. In this case, it is not visualized. So it will be visualized and you can always say, so coming back to collapse, if the lesion is obscuring somewhere here, this lesion is obscuring somewhere here, and if it is obscuring the left hemidiaphragm, then it is a left lower collapse. If it is obscuring the right hemidiaphragm, it's a right lower lobe collapse. Is that okay? That is why I wanted to put this. Just again, importance of Silhouette sign and collapse. What is this? Just describe. Dr. Swaksh.
Yes, sir. This is a frontal chest radiograph. The scapulae and vertebrae, scapulae, ribs, and clavicles are normal. There's blunting of both the costophrenic angles, left more than right, suggestive of pleural effusion. The lung fields appear normal. The In the superior mediastinum there is
Am I audible?
Obscuring the
You're not audible. Hello.
Your voice is breaking.
Mine or Dr. Swaksh?
I can't hear him either. Let's just wait for a moment.
Yeah.
Yeah, we can still see them, and let me just call them.
So am I audible now?
Yeah, you're audible. You're audible. Perfect.
So should I start over or
Okay, just tell me. I think so. Why I want to show you is this is what do you think this is? Just come to the diagnosis.
so left pleural effusion?
Very good. How do you define this? Well-defined opacity, left lower lobe with upper margins, all that stuff.
So it's a well-defined soft tissue opacity with a concave upper margin. It's obscuring the left CP angle and the left dome of diaphragm and extending along the costal pleura on the left.
Perfect. So now, where do you think the effusion is? It fills the posterior CP angle first, and then it comes up. Is that okay? That's how it is. That's how it is.
Yes, sir.
Okay. So what I want to say is that in collapse, the left or medial mid of the left hemidiaphragm is generally obscured. In a pleural effusion, generally the entire thing will be obscured. Okay. That is why I have kept this X-ray. Okay. So the importance of a Silhouette sign in collapse is that in pleural effusion, the entire hemidiaphragm will be obscured generally. And in this, it will be the medial side of it. Okay. So this we will skip. I will just take 1 minute to just wind it up. So this is the right lower lobe collapse. Okay, again, and important thing is the left and the right descending pulmonary artery, which is something like the little finger, whereby this thing should be generally seen. If you are not seeing this, probably this has been obscured by the collapsed segment. So this is very important in case of very steep left lower lobe collapse. Okay. So I think this is again left and right I have already discussed. So this there is one collapse over here. If you can see, this is one collapse. This is the minor fissure. One of the minor fissure. I think that time we will otherwise we don't have time to discuss all this. But yes, on the right side there is one collapse, and on the left side is one collapse. What do you think? This is a right lower lobe collapse or a left lower lobe collapse? Dr. Swaksh?
Yes, sir.
What do you think? Right lower lobe collapse or a left lower, or whatever, right lower lobe pathology or a left lower lobe pathology?
So left lower lobe pathology.
Okay, and why is that so? Why did you say that? This one?
So because the right hemidiaphragm is seen completely, whereas the left hemidiaphragm is still evident.
This one you are calling it left hemidiaphragm, right? Where the arrow is.
So where your arrow is right now will be the right hemidiaphragm because you can see it till anterior.
Okay, so this arrow, this is on the see there is this is the stomach bubble. Okay, this is the stomach bubble. Can you see this? If it is a stomach bubble, it is
Okay.
left. Okay, in a normal case, if there is no situs inversus, it will be the left hemidiaphragm. It is very sharply defined. Okay, so it is not a pathology of left side. It is pathology of right side. Got the point? Got the
Yes,
point?
sir.
So that is the way. And I don't know, one mnemonic I always say DDD. In a normal lateral chest X-ray, density decreases downwards. That density of the spine decreases downwards. Why? Because the air component becomes higher. Lung is very, the mass of the lung is higher on the lower side, and on upper side, scapula, etc., makes the density on a different scale. So it is density decreases downwards. So blackness decreases. And if there is anything white, it becomes an abnormal thing. Is that okay? And here again, this is a collapse of one of the lobes. I mean, one of the right lower, we will, I think we will skip this as of now. Okay. So let us come to case 2. I think we are already 30 minutes. Okay. Who will take this?
Yes, sir. Me, Milan.
Milan. Hi, Milan. So now
Hi, sir.
you take this. Describe it. 55-year male, diagnosis, loss of weight, a frontal chest X-ray.
Uh, so there is an ill-defined hazy opacity involving left upper lobe and left middle lobe of
Okay.
left upper and left middle lobe with pulled up left hemidiaphragm, and it is seen obscuring the left heart border.
Mhm.
With the right, so there is actually hyperlucency in the right lung field, suggestive of hyperinflation.
Okay.
The bones appears normal,
Okay.
and there is loss of lung volume on left side.
Very good.
So there is a mild shift of the mediastinum towards the left,
Yes.
and so this could represent left upper collapse.
Okay. And what do you think the most common common reason? Male, age 55, diagnosis, loss of weight.
Hello.
What would you think the most common cause in this case? In a case of 55-year-old male?
So this could. So we have to suspect malignancy in such
Very
patients.
good. Very good. So will you look for a mass lesion in and around hilum?
Yes, sir.
Do you think there is some? What is this?
Yes, sir. There is a
Okay.
well-defined opacity
Okay.
in the
So,
left hilar region, sir.
yes. Okay. So see, that's what I tell you, that you have described all the finding, you know everything, but still you have not, you have to, everything has to be systematic. This is a frontal chest X-ray of a male 55 years with diagnosis loss of weight. there is a well-defined veil-like opacity in the left upper lobe or upper zone and left middle zone, okay, with air bronchogram, without air bronchogram, with calcification, without calcification, with air fluid level, without air fluid level, and then subsequently it is causing, if there is a loss of volume, what will you say? Loss of volume, there are 4 or 5 things. Mediastinal shift, hilum pulled up, hilum pulled down, left hemidiaphragm pulled up, left hemidiaphragm, whatever, pulled down, crowding of ribs. And, these are the things which are there, which you have to say. Then subsequently, there's a very important thing out here. What is this? What is this? There's something called Lufteschel sign in left upper lobe collapse. Okay,
Yes.
okay. So um, Lufteschel sign. So what happens is, how does it come? The pathology is there. Okay, so I will come to that. So this is the left upper lobe collapse, and the most common thing, most common history which you will take is smoker. Okay, smoke. The examiner has to know that you're just not a radiologist, you're a clinical radiologist. Okay, and you're thinking on the lines of treatment rather than just giving a diagnosis. In this case.
So we would suggest HRCT thorax and a contrast and
Okay, why won't you take this? Which one is what? Just describe
so
it.
the arrows represent
Not
collapsed
first
part of the
time
lung.
actually.
So
Okay,
and
so what it would be, and what? So which one is anterior? And this, what is this? What is this? And what is this?
so there is hyperinflation of the
Of the
rest of the lung on left side. So left lower
very
lobe.
good. So which one is left lower lobe? This or this? Posterior or anterior?
The posterior one. So
Very good. So now the thing is that the upper and the lower lobe has hyperinflated and taken the, it has gone and taken the position of the left upper lobe. Is that okay? On aortic knuckle gives you the tuft of air sign. The Luft sign. That is that causes a curve around that aortic knuckle, and this gives the Lufteschel sign on the frontal chest X-ray. Okay, so that is okay. So this, after this, you can follow it up with chest X-rays and all. I mean chest CT and all. Same thing. This is chest CT, CCT. There is a collapse. You can see there is a collapse. You can see, and there's probably the mass golden S sign, which we can see here. You know what is golden S sign?
right upper lobe.
What is that?
I mean when there is collapse of right upper lobe. So
Okay.
yes.
What is this? Very good. Again, do you see,
No,
see
so
any
there
air
is no air
bronchogram?
bronchogram, no air fluid
See?
level, no calcification.
Yeah, because if there is an air bronchogram, what would it become? Well, it generally indicate pneumonia. Okay.
Yeah, consolidation.
If there is an calcification, what it can indicate? See, this is classical, but it can indicate something, anterior mediastinal mass. What is calcification in anterior mediastinal mass? Classical.
So thymoma.
Exactly.
Or
So yeah, so some teratoma thymoma complex.
yes.
What I'm telling you is, see, since our brain is presently concentrated here, in collapse, we are not thinking on those things. But in examination, it can be anything. Okay, so everything it has to be broad horizon. Okay, fine. What do you think this is? This sharp margin. What is this?
So that is the right horizontal fissure, sir.
Very good. So this is a well-defined homogeneous opacity in the right upper zone extending from the periphery to the hilum. The inferior margin is oblique and it's likely the right minor fissure which has been pulled up. Is that okay? And there is some probably abnormality out here, and this is the golden S sign. This is collapse of the right upper lobe, and likely there is a right hilar mass. Is that okay?
Yes,
Is
sir.
that okay? Okay. So fine. This is what it is. And what will you do next? Maybe in FRCR, the answer is that you refer these cases to the MDT chest. Okay. Or maybe work up the CT tap and then refer it to MDT chest. I think for a clinical and histopath evaluation and further treatment. That's your answer. It should be. Okay. So this is the golden S sign, which is something like this, and which is actually the collapsed lung over the mass lesion. Okay. So I hope this is clear. And this is a very important slide. I think from teachers of your KM also used to teach us. So in a middle-aged smoker, bronchial carcinoma is the thing. 2 days after surgery in the intensive therapy unit, if you see a collapse, it is a mucus plug or incorrect position of the endotracheal tube. Asthmatic mucus plug and toddler or young children, if you see, it is an inhaled foreign body. Okay. So this is how the clinical mind of the radiologist should work. Collapse can be there, but the reason has to be worked for it. Again, type of collapse you must be knowing. This is obstructive, something like the airway has been there's some lesion in the airway that can be intraluminal, that can be wall, that which obstructs the air intake, and the whole thing is resorptive. Then there's a compressive, some lymph node or some mass compressing onto the airway, and that can be there on the medial side. On the periphery, pleural effusion, pneumothorax, adjacent intrapulmonary space occupying lesion, all that stuff can compress. Then cicatrization, that is post TB in our case, our means Indian cases, whereby that's most commonest, whereby the cicatrization is basically fibrosis where the whole thing contracts, and then subsequently radiotherapy and idiopathic pulmonary fibrosis are other things. And collapse and atelectasis is common in a neonatal surfactant deficiency, premature 32 weeks and less. In this case can be seen, and adult respiratory distress syndrome is other, and complication of spokes inhalation. This slide, I think you can just take a picture and maybe make a note of it. This is very important slide for exam point of view, anywhere. Okay, this normal fissures you can study from Sutton. I think that is good enough. And then we go to case 4.
Yeah. Thank you, sir.
Thank you. Please go ahead. Who is taking this? Who is taking this?
So Swaksh.
You have taken, you start frontal chest X-ray, and then you keep seeing. Okay, learn that art, because the examiner doesn't like you quiet for 15 seconds, 30 seconds. No, वो अच्छा नहीं लगता.
Yes, sir. So frontal chest radiograph in a female patient shows the ribs, clavicles, and scapulae are normal. The both costophrenic angles are normal.
Okay.
The left lung field is normal. However, in the right lung field, in the mid and lower zones, there is a hazy opacity in the right middle lobe, since it's silhouetting the right heart border.
Okay.
It's seen. It's a hazy, ill-defined soft tissue opacity. There is no uh, calcification or air fluid level within,
Okay.
and it is seen separately from the right dome of diaphragm.
Okay. What about the right vertebral margin?
So
Clear? Generally clear?
yes, not sure. It's
Right heart border?
so it's right heart border is not seen clearly. It's obscuring the right heart border.
Rest of the things? See, with this, if you're suspecting a mass lesion, you also should look at the bones to see whether there is any metastasis or not. If it is in metastasis, the issue is over. Okay, this is a mass lesion. That's one. Do you see anything in the bone? Probably no. Okay. Probably no. Hello.
Yes, sir.
Yes. And the second important thing which you picked was bilateral. It is a female patient. The other line should be bilateral breast shadows are normal. Why?
Yes.
Because why? Because if see now there are multiple permutation combinations here. If it's a bilateral breast, if you see a unilateral breast, most likely it's the case of CA breast. Okay, and if there is a unilateral breast with some lung lesion, then you are there at the answer. You get the answer. If the unilateral breast with some rib lesion, you get the answer. Unilateral breast with some vertebral collapse, you have an answer. You are straight away pointing at a diagnosis, a pinpoint. Okay, so that is how you work on a chest X-ray. And if you say, if at all, say a unilateral breast, sir, there is a mass lesion in the one of the ribs, or if there's a vertebral compression fracture, most likely it's a CA breast with METs. Examiner is just going to clear you there, then and there only. He will not even go to CT scan. Okay, so that is how your mind should start working. Okay.
Yes, sir.
So what do you think that is? The one which diagnosis, differential. Let us discuss. You don't have to be right or wrong. There's on
Sir, it's
chest
an
X-ray, nobody wants a diagnosis. You just say,
sir,
what do you think?
it's a airspace opacity. So there are air bronchograms in it. So
Okay.
consolidation.
Of
It could be due to,
of which lobe?
so right middle lobe
Very good.
consolidation.
Or if it say,
And
I would
in
say the right chest, right cardiac margin is well visualized, then this would be which lobe?
right lower lobe, sir.
Very good. So now it is either consolidation of right middle lobe or it is either consolidation of right lower lobe. You have one consolidation or collapse, consolidation collapse complex. That's one. What is the second DD?
So since it's ill-defined, it could be a mass.
Okay. What is the third DD? See now what I was not interested in that second DD. So I have gone to third DD. So the indication is that that is not the answer. Got the point? As if you have to decipher from examiners. Okay, what is the second? Okay, now tell me the third one. That means the second thing is not the answer. What do you think next? What
So
is
aspiration pneumonitis.
very good? Aspiration pneumonitis can be there. So which is the most common lobe of lung or segment of lung which is involved in aspiration pneumonitis?
So right lower lobe.
Okay, very good. So if it is an erect patient, right lower lobe. If it is a which segment? And if it is a lying patient, which segment? Okay. Again, so now it is, if it is a erect patient, this can be a aspiration pneumonitis. Okay. In lying, it is the superior segment of the right lower lobe. Fine, fine. So let now think, what is the next DD?
Sir, soft tissue mass in the right breast.
Too far-fetched. But yes, chalo, wo bhi diya. देखो, what I want to say is, no, कि you people have to discuss middle lobe collapse का the DD is pectus excavatum. That you have to know कि A के बाद B आता है. Okay, A के बाद Z नहीं आता. So if it is a middle lobe collapse, the next DD should be pectus excavatum. It is so. How do you see the history? History of frequent fever, cough, all that shit. Then, sorry, all that thing. Then it is on the infective side. Asymptomatic patient walking to you, and this most likely it is pectus excavatum. What do you think? What do you look at pectus excavatum? 7 sign. 7. मतलब 7, number 7 sign. Where do you see? This is the 7 sign. This is the 7 sign. Okay, ribs. This is the 7 sign. Fine. दिख रहा है ये 7. दिख रहा है arrow?
Yes, sir.
This is the 7 sign. So if you see the 7 sign, see, the thing is that I know it is becoming very easy for me to, show everything to you, but it is difficult. This is the number 7. Okay. And why it is so, I will disclose. This is the number 7. So if it is a steeply turned anterior ribs, not the posterior one, anterior ribs, then you should think of pectus excavatum. Okay. Fine.
Yes, sir.
Let us see. So now you have middle lobe collapse, consolidation, lower lobe collapse consolidation. Third you said was third you said something, and fourth is a pectus excavatum. With this, you take a history that infectious history hai nahi. Infectious means fever, pneumonitis and all. And if it is there, if it is not there, and then we are going ahead. If it is an infectious history, infection ka history or fever hai, inflammation ka history, then it is a consolidation collapse. If it is not, then I will go for a lateral chest X-ray. Okay. This is the lesion and this is the pectus excavatum. Can you see the sternum going behind? And this is the breast. Okay. This is the
Yes, sir.
generally sternum yahan hota hai. Okay. So now why the anterior things are vertical is because generally the vertebra, anterior ribs will start and go like this. Anterior will start and go like this. Okay. But here it is behind. Matlab, if you see, if I draw a line, the sternum or whatever, if the sternum is like this, so the same thing has to go and get attached like this. So it becomes vertical. And that is why they are vertical and gives you a 7. Got the point? The posterior
Yes,
ribs
sir.
are fine, the anterior ribs goes and gives you an angle of. So this is how it is. So this was pectus excavatum. Okay. Sorry, I think in this the right one there is some consolidation. Okay, but that is how the whole funda is. Fine. Again, what I'm telling you is that again in this one what we missed is this is a normal one. Normal in the sense it doesn't have here we can see a subtle. How do we delete this? So here we can see a subtle hypointense lesion like a coin going across the cardiac shadow. Can you see this? I'm not able to delete it. Okay. So,
Yes, sir.
so this is a left, right middle lobe consolidation, right middle lobe consolidation below, and upper it is the pectus excavatum. That's what it is. Okay, fine. So this CT is of this probably this. Fine. Okay.
Yes, sir.
So let's see everything. This is right heart border is obscured. Here you can see a coin-shaped lesion obscure. Over the cardiac shadow. Here, if you can see the coin-shaped in the cardiac shadow, and this is confirmed on CT. What is a Lady Windermere sign? Have you heard of it? पढ़ लेना ठीक है लेडी विंडरमेयर साइन करके कहता है दिस इज
Yes, sir.
a chronic right middle lobe collapse in an English woman करके है and she presents as a chronic cougher. Okay, so that's how it is, and this basically because of the right middle lobe collapse. So this is the pathology. This is the right middle lobe, and this is the right middle lobe collapse. This is the oblique fissure, and this is the right minor fissure, whereby the right minor fissure goes caudally, and then the whole collapse takes place. Okay. Yep. Okay, so this is pectus excavatum, and the whole pathology I have already explained it to you. This is the sternum and the xiphisternum, sternum and the xiphisternum, and the whole thing becomes more of a vertical this thing. Okay. Now, I will these are all diagrammatic representation of silhouette sign applicable in collapse. So if you see, what is this? If you see here on the first thing, the left hemidiaphragm is obscured, right?
Yes, sir.
Okay. So, and on again, here, the left border of the heart is obscured. In C, the middle lobe is obscured, and in D, the right hemidiaphragm is obscured. So this all indicates a left lower lobe pathology, a lingular lobe pathology, a right middle lobe pathology, and the right lower lobe pathology. Okay.
Yes, sir.
And pneumonia and the silhouette sign both go hand to hand, and that is how we interpret the chest X-ray. There are again some flaws of silhouette sign, which in fact we discussed in our discussion, that here if you see a lesion in the right heart border which is not obscuring the right heart margin, it is not in the mediastinum, or maybe it is either most likely it is posterior, it is not right middle mediastinum. Is that or right middle lobe? Sorry, not mediastinum, right middle lobe, because it is anterior or posterior to heart. You understand this?
Yes, sir.
Okay. And on the left, it is the same. If it is not obscuring the left border of the heart, it is either anterior or posterior to the heart. Okay. And mostly these are the lesions which are seen in the paravertebral gutters posteriorly, and which is generally the anterior part of the diaphragm is higher than the lesion, and that is why they don't obscure the diaphragm. So anything which will be deep in the posterior CP angle in the paravertebral location may not obscure the left hemidiaphragm. That is the message I want to convey to you. Okay. I think things are over. This is just repetition. And again, collapse in the right upper lobe. There are azygous fissure, unfolded neck vessels in the elderly, usually only in supine chest X-rays. Basically, these are all fat deposition which can be seen. Middle lobe collapse, the DD is depressed sternum and normal vessel of fat touching the heart border. That is the epicardial fat pad. And again, in right lower lobe collapse, epicardial fat pad and accessory fissure can be some differential diagnosis. Left lower unfolded aorta, hiatus hernia, and left upper lobe is unique. So you just have to, if you see a left upper lobe collapse, you describe it, and in 30 seconds you should be out of it. That is how it is. This is an azygous lobe fissure, just for, and since the differential is here. And I think I have finished on my part. Hello?
Yes, thank you, sir.
Thank you so much, sir. This was really phenomenal. And great job, guys. You were really good at, what is not an easy thing to do, going live and interpreting chest X-rays. I think much more difficult than interpreting CTs or MRIs. So thank you so much. There are a few questions in the Q&A. You can take that, sir. Poonam is asking, do we talk of mediastinum? So this is regarding the first case that you showed.
Mhm.
Talk of collapse. Do you say you talk of mediastinum involved in the collapse or lobes involved in the collapse?
Lobes. I think at times that was a mistake from my side. It's lobes.
Okay. You touched upon differentiating right and left lateral X-rays.
Hmm.
Can you just elaborate on that? That was one of the questions from an anonymous attendee.
Okay, so right and left, in the sense, see, it's a very tricky topic. First and foremost, there are, I mean, in fact, Ravi Ramakantarsan only he was expert in this. See, if it is a right lateral chest X-ray, when the right lateral border is towards the film, then the right hemidiaphragm would be higher. Okay, and the left hemidiaphragm would be lower. Okay, why? Because the X-ray tube, it is generally at the level of T4. So if you go by physics, it is like that the left diaphragm, which is away from the film, will be projected lower to the right diaphragm. And most likely, vice versa also, it should be true. That is one. But in a case where right and left hemidiaphragm, it is not it is not sacrosanct that it will be right side only which will be higher always. It becomes a difficult thing. So examiner just have to tell the examiner that this is like this. Secondly, on a right lateral chest X-ray, same as AP view and the PA view, in AP view, cardiac shadow is magnified. Same, because it is anterior and at a distance from the film. In a right lateral chest X-ray, it will be magnified. In a left lateral chest X-ray, it will be, normal or smaller compared to right. These are the two things generally which I know of how to differentiate. But it at times will be difficult. We can differentiate the hemidiaphragms very easily, but right and left lateral at times may be difficult.
Thankfully, my examiner never asked this in my exam.
And yes, one of the most difficult topic if somebody gets that.
This is a question you had, covered this in a previous session. What is subpulmonic effusion? But I think it's important.
Okay. Subpulmonic. See the two spaces. One is Pleural, we all know that pleura has two. One is a visceral pleura and other is a parietal pleura. We all know this. So anything between the visceral and the parietal pleura is pleural effusion. Okay. Anything between the lung and the visceral pleura is subpulmonic effusion. Got it? Anything between the lung and the visceral pleura is the pulmonic effusion. Subpulmonic means lung ke niche, effectively. I mean, it goes all around, but so between visceral pleura and parietal pleura, it is pleural effusion, and between lung margin and the visceral pleura, it is subpulmonic. So both, just go and see the picture of chest X-ray frontal view in a subpulmonic effusion, whereby the lateral half of the hemidiaphragm will be elevated. Okay, and you just keep that picture in mind. That is it.
Okay. Brinda is asking, does aortic arch obscuration imply a posterior mediastinal pathology?
Yeah. Yes. If you go to Radiopedia, just go to Radiopedia and type silhouette sign in chest X-ray. They will give you 7 or 8 points whereby the silhouette sign is applicable. This is one of them. If the aortic arch is obscured, it indicates. The only issue is that aortic arch comes from posterior to anterior. From anterior to posterior on the left side. In that case, what happens? Anywhere if it is obscured, at times it becomes difficult to say where it is. Like in left upper lobe collapse. When the collapse happens, the whole thing shifts anteriorly, and the posterior aortic knuckle is obscure. I mean, it's marginalized by the air in the hyperinflated air in the left lower lobe goes and in and around the aortic knuckle. So over there again, the silhouette sign is a bit falsy, but otherwise, yes, it should be there. It is applicable. Radiopedia, chest X-ray, silhouette sign. You will get the answer.
Okay. One anonymous attendee is asking, for the last case, would you call it in the exam? Should you just describe pectus, or should you call it pectus with Lady Windermere?
No. The upper case was pectus and the lower case was Lady Windermere. See, there were two cases. If you go, there were two cases in that. So the upper case was pectus.
Bethlehem is asking, is there a cutoff to say mediastinal widening? What is your subjective take on when do you call it mediastinal widening?
Mediastinal widening is again, there are some mathematics to it. It's the right paramediastinal border and the left paramediastinal border, and then there is some measurement. It's again given in Sutton. Okay, but again, Sutton it is already given, and that should be followed. There's some millimeters plus minus so and so in male, and some millimeters plus minus so in female. Sutton normal chest X-ray or the mediastinum, and the first chapter or the mediastinal chapter, it is given. She can check it.
Perfect. And another question from Bethlehem, is the descending pulmonary artery always visualized on chest X-ray? Is the left descending pulmonary artery always visualized on chest X-ray?
In a proper exposed film in a normal chest X-ray where full inspiration is taken, it will be visualized unless it's absent.
Okay. Abby is asking, how would you describe hilum convergence sign in the exam? Should we describe as vessels converging within 1 centimeter from lateral edge, or by the other definition?
What is that other definition?
Sure, Abby has not written that.
Hilum convergence sign is okay. So hilum convergence sign is something like this: that vessels bronchovascular marking, hilum convergence bronchovascular marking converge onto the left hilum and the right hilum. Fine. So now, if that convergence is not seen by, say, if there is a mass lesion or some soft tissue density lesion, if it is not seen there, then if it is not seen, that means that lesion is around the hilum. Okay, and if it is seen through and through that lesion, that means that lesion is either anterior or posterior to hilum. That is how. That is called hilum overlay sign. And this is a hilum convergence sign. I hope Abby is clear on that. Abby asked, right?
Yeah.
Yeah. So it is not, this sign is not negative or a positive thing. It is like bronchovascular marking converging to hilum if it is seen, and the lesion is seen through and through, I mean, the vessels are seen through the lesion. That means it is not in the region of hilum. It's same as silhouette sign, basically.
Yeah, essentially all the signs are application of silhouette, isn't it? The
Yes,
hilum,
yes,
the
yes,
hilum,
yes,
the
yes.
hilum.
Yes.
Okay, we have some time. So this is, can you explain again aspiration pneumonia on the erect and supine X-ray distribution?
Okay. So why it goes to the right side? It is because right is lower, right is steeper, right bronchus, right main bronchus. Right is lower, right is steeper, and right is posterior. The three things. The third thing I'm missing. The three things peculiar to the right main bronchus. Why it goes to the right side and not to the left side? Okay, so right main bronchus is lower than the left main bronchus. Right main bronchus is steeper to the left main bronchus, and thus anybody who is erect, it will go to the right lower lobe in one of the segments which is lower. Generally, I think, again, please check it, is medial, or that's LAMP. It is medial or posterior segment of the left lower lobe, right lower lobe. One of them, please check it. I'm not too sure on that. But that is the funda. But if the patient is supine, then the superior segment of the right lower lobe is where the aspiration pneumonia takes place. Because in a supine position, it just goes into the superior segment. That's it.
Perfect. Bethlehem is asking, is the collapse sign also applicable for neonatal X-rays?
Yeah. Yes, it is applicable for any X-ray. That is what I said. No, in a foreign body, like in a child coming with breathlessness and a collapse of whichever segment, the first thing is to rule out a foreign body. And if it, I had shown one slide whereby if it is an ICU setting, mucus plugs. If it is bronchial asthma, mucus plug. And ICU setting, my other thing is that, endotracheal tube and all that stuff. So it happens in all ages. Age-wise distribution of the, causes of collapse was given in that slide.
Okay, I think this is a comment on the lateral X-ray discussion. Descending aorta is seen better in left lateral than in right lateral X-ray, is what
Maybe.
comment. I'm not sure.
I'm not too sure on that.
Okay, and a request, which is, please do a webinar on congenital heart disease. So perhaps one of your future sessions can have
On chest X-ray, right?
Yeah.
Okay, give me some time. I'll try. Anything else? Anything else like trauma side of trauma again is one very good area of chest X-ray. I mean, on an X-ray, if that is one way we can have a detailed session.
Absolutely. So
Let us
just
see.
for all the attendees, sir has agreed to take a series of sessions on conventional radiology, and we can definitely keep doing them, regular.
Yes.
Thank you so much for that.
Let us see congenital, and I will work on that thing, and I'll let you.
Perfect. Okay, so thank you so much. I think we've answered all the questions, and thanks a lot to the volunteers. I mean, you guys were really fabulous.
Yes.
Thank you.
At times, I also get stressed coming in front of, second and third year trainees who will, these many questions you tend to forget, But anyways, I think thank you. Well done, both of you. And you were really good. And I just want you to practice yourself in front of mirror. And that's it. I think your level is very good. Okay. Excellent. Keep it up.
Thank you so much.